at the end. So I'd like to welcome Maria Noan. She's our cash advisor and supporting the UNICEF clusters in Somalia, as well as Andre Dour, who's our cash advisor from the Global Nutrition Cluster. Over to you, Noan.
Good morning, everyone. Thank you, Naima. My name is Noan Laida. I am supporting the UNICEF-led clusters in Somalia. So UNICEF has mandated my position to support their clusters with knowledge and capacity in the utilization and also in the expansion of cash and voucher to deliver emergency programming. As you know, there's a growing caseload of undernutrition in Somalia, and nutrition-sensitive interventions using cash and voucher is a key focus. The use of cash programs in delivering or complementing nutrition activities is an area to be developed further by nutrition practitioners in Somalia. Currently, the use of cash to deliver nutrition programming is very low. This year's HRP only represented 1% of the sectoral budget of cash and voucher. The nutrition clusters, however, really interested and engaged in changing the status quo. And in line with this, to support my role, they have created a task force with 4 nutrition partners. In this task force, we have FAO, Concern, New Ways, and Save the Children. They are providing nutrition expertise to my work plan and will be supporting the activities that they deliver for the cluster. They will review all the products before it's being shared onwards with a nutrition cluster partner. The first activity that has been undertaken by the task force is the design of, can you please mute your mic if you're not speaking? Thank you. So the first activity that was undertaken by the task force is the design of a nutritious food MEB. You will have an opportunity to hear from the group as we progress with the webinar. I will invite my colleague from Save the Children, Aidan, who will present to you the cost of a nutritious diet in Somalia. The task force that was created by the nutrition cluster will also be responsible to take forward the recommendation that will emerge from this webinar today. Now I would like to invite my colleague, Andre Dour, who's been doing quite a lot of work in cash and nutrition globally and in Somalia, and it's the reason we are all joined here today. Over to you, Andre.
Thank you very much, Noan. So welcome everybody. My name is Andre. I work with the Global Nutrition Cluster, seconded by CashCap. I've started with the GNC back in August of last year, and basically my main mandate is to develop guidance on the use of cash and vouchers for nutrition outcomes. As part of that guidance development process, we have also selected a couple of case studies to further explore practice and lessons learned. And one of these case studies has been Somalia. And that's why we are actually gathering here to look at some of the, well, first of all, to look at some of the elements of the guidance that is being developed, but then also specifically looking at some of the project examples in Somalia and what we can learn from them. And then in a second step, also to look at cash and voucher assistance, not specifically meant to contribute to nutrition outcomes, but what we can potentially do to apply a stronger nutrition lens to these cash and voucher interventions. Yeah? So yes, thank you all for introducing yourselves in the chat box. I see we already 44 participants, so we're not going to be able to make a round, but I can see that a lot of organizations are represented, which is great. And like Naima mentioned, if you have a question, please write it into the chat box and we'll take it up later. Can you all see my screen?
Yes.
Yes, great.
Yes,
okay,
yeah.
Excellent. So quickly to the agenda of today. Yeah? As I already mentioned, part 1 will be more focused on actually the content of the guidance, but that will be relatively quick. So we'll look at some of the key frameworks and messages that are coming out. By the way, the guidance, the evidence and guidance note is currently in its last stages and will be officially launched in August and launched with the nutrition cluster coordinators at the end of July. So it's really coming out very soon, and you will all have the opportunity to have a look. It's a bit long, but there will be also a shortened version produced once the evidence and guidance note is finalized. So that's part one. Then part two is looking at experiences in Somalia. I'll take some time to do that, and also then open the floor for discussions, for questions, for suggestions, for contributions, etc. Then, as Noan mentioned, we're going to look at specifically the cost of the diet and the balanced food basket as one important component to apply a stronger nutrition lens to household cash transfers. We're going to have a quick look at the recommendations at the end, and then again open up for questions and answers. Good. Okay, now since I think most of you are probably nutrition practitioners rather than cash practitioners, we thought it was important to briefly introduce the most important terminology when it comes to cash and voucher assistance. So I'm just going to go through it. If you have any questions, please raise it in the chat box. So CVA, cash and voucher assistance, is the provision of cash or vouchers to targeted recipients, can be individuals, households, and rarely also communities, to access goods and services to address their needs. In the context of nutrition, I think it's important to mention what is not considered cash and voucher assistance. So for example, payment of incentives for volunteers or community health or community nutrition workers, we don't consider that a CVA because these are not our targeted beneficiaries. Payments to institutions, for example, to schools, for school feeding, to health centers to support them, etc., are not considered cash and vouchers because they're not targeted towards individuals or households or communities. So it's really the targeted recipients, so the ones that we actually want to assist. I think that's really the key. Then we can distinguish between sector-specific cash and voucher or cash and voucher that is maybe more focused on basic needs. So, for example, in Somalia, you have, for example, the cash transfers that are calculated based on specific food needs. That would be maybe more sector-specific intervention. And then you have the multi-purpose cash transfers, which amount is calculated on needs across different sectors, and they are supposed to address broader basic needs. That can be one distinction. Then another one, an important one, is this distinction between unconditional and conditional. I think there's still quite some confusion around these terms. So essentially, a conditional cash transfer is a transfer that beneficiaries have to do a specific activity in order to be assisted. So it doesn't necessarily only apply to cash transfers. You can also have conditional food transfers. So people have to do something in order to receive the assistance. It has nothing to do with how the money can be spent. That's a different thing. And in nutrition programs, the most common conditionality is either participation in social and behavioral change activities, so face-to-face sessions, and people will only get monthly assistance if they participate in these sessions. Or the other one is actually attendance to health services. So your household will get the money, but you have to visit antenatal care, or you have to go for vaccination, or whatever it is. So these are the two common conditionalities as part of nutrition programming. And of course, there is others related to education, cash for work, etc. Then in regards to utilization, so that there we talk about restriction, yeah? So restriction on how the assistance can be used. And here we basically distinguish between cash, which is by nature unrestricted. So if you give cash, people will spend it on whatever their most pressing needs are. But of course, you can potentially influence that choice. For example, by labeling, so by saying, okay, this is for your food, yeah. Or even better and more sophisticated, by introducing social and behavioral change communication, where you explain a nutritious diet and how money can be spent on these foods and how these foods can be prepared, and other aspects related to health and nutrition as well. So that is unrestricted cash, unrestricted. Vouchers are considered restricted because you cannot redeem them everywhere. You have to go to specific shops. And within these shops, you usually cannot buy anything, but you can only buy whatever is approved as part of the contract with the vendor. So for example, a fresh food voucher can only be used to redeem, to purchase fresh foods that are approved. Yeah. And again, with vouchers, you have different design options. Can be commodity or value voucher. A commodity voucher essentially is exchanging a voucher against a ration, a pre-identified ration. So you don't have any choice. You go to the shop and you get 10 eggs and a kilo of cabbage and a liter of oil, and that's it. Or a value voucher, which has a monetary value, and you can choose within maybe 10 products, and you can use that value voucher then to buy according to your requirements among the selection of approved food commodities, for example. Yeah. Same applies, of course, also to other commodities related to wash. Can also be related to services vouchers, of course, etc. Good. And then lastly, delivery mechanisms. So how do we do the transfers? How do they end up in the hands of our beneficiaries? So cash in principle can be done electronically, like I think most transfers are done in Somalia. So for example, mobile money or a bank account or a debit card, etc. Or it can be cash in hand. So for example, cash in envelopes where you hand over the cash, like in a physical distribution, or it can also be over the counter where you require targeted beneficiaries to go to a bank, to go to a post office, to go to a hawala and identify themselves and then receive the money over the counter and take it home. Yeah. And vouchers, primarily you have paper vouchers and electronic vouchers. Paper vouchers are a piece of paper where your entitlement is basically written on and that have some security features. E-vouchers are usually in the form of a card, and there's different systems that support e-vouchers, including, for example, Scope, which I know is also being used, promoted by WFP and being used in Somalia, but there's other solutions, Red Rose, Segovia, etc. Good. I hope that is clear. That was a bit fast. Let me just see if there's any questions. Not so far. Good. Okay, we continue. Good. Okay, so this nutritionists know, or maybe actually this is the updated framework for child and maternal nutrition by UNICEF. So it's based on the previous one, but it has been updated a little bit in terms of language. It was included in the last State of the Children report. So you have the underlying determinants or causes related to food, to feeding and care, and to healthy environment. And then you have the immediate determinants related to diets, so to individual dietary intake for children and women, as well as care, health for children and women. And as the ultimate outcome, you have, of course, improved nutrition, nutritional status, growth, cognitive development, etc. Yeah. Just to briefly show you where, like if you give a household or an individual as well cash, essentially a cash is a financial resource, like income, like remittances, like other things. Yeah. If you could please mute yourself. Thank you. So it lands essentially there, you know, cash transfers as well as vouchers as well, I would say, or financial resources. That of course can then be used to address underlying determinants of malnutrition. Yeah, so you can of course spend it on food. You can spend it on improving water and sanitation of your household. You can spend it on water. You can spend it on health services. You can spend it on food for your children, on complementary feeding, etc. The cash itself also can have, like, the fact that the household has more cash can lead, or has proven to lead also to or have a positive contribution to some of the underlying determinants of adequate nutrition. For example, it has proven to, or it can lead to, for example, decreased household pensions, to better decision making, or empowered decision making for women, etc. So that it can also have that positive impact on the care aspect, simply by having more money within the household. Yeah, there's also a few examples, obviously, where it can have negative impacts, so it can potentially lead to increased household tensions, or it doesn't necessarily lead to better or to improved participation of women in decision making. But overall, I think the evidence points in a positive direction. So essentially, cash transfers as well as vouchers, they can address the underlying determinants of adequate nutrition. And the most the strongest evidence is actually within the food security pathway. We have some evidence as well for the health pathways, who increase the access to health, etc. For the care pathway, there's less evidence there. Yeah. Okay, so this is just because the next slide will look at some of the barriers on the supply and demand side to adequate nutrition, and I just wanted to point out that these barriers are according to the underlying determinants. Yeah. So key message here: cash and voucher can help to directly address the underlying determinants of malnutrition. It is certainly less adequate to directly address the immediate determinants. Good. So don't be shocked. I know there's a lot of content here. The idea here is really to make you think about barriers to adequate nutrition at the underlying level. Yeah. Can everybody hear me? I can see some comments that yeah.
Loud and clear. Yeah.
Okay, good. So these are barriers to adequate nutrition, sorted according to the underlying determinants, and we divide them into demand side barriers and supply side barriers. Yeah. So the demand side barriers, for example, to food, is everything related to the household access to nutritious and healthy foods. The supply side is more than the provision or the making available of these foods in local markets, yeah, as an example. What is highlighted here are economic barriers. Yeah? So economic barriers are essentially things that can potentially be addressed with a cash and voucher approach. So, for example, nutritious food is not available, is not affordable for families. Yeah? Transportation to markets is not affordable. So that will be, for example, on the food security side. On the feeding and care side for children, we have, for example, nutrition-dense complementary foods are not affordable. We have the lack of caregivers' time for optimal feeding and care due to other priorities. So, for example, they have to work. They don't have enough time actually for good feeding practices because of economic pressure, and that can be partially addressed with more household income. Then on the health side as well, health services are potentially not affordable because of out-of-pocket expenses related to consultation, medication, accommodation at the health center, etc. Transportation can be an issue in terms of affordability. Opportunity costs, so the costs of actually spending a time in the health center rather than actually going to the field and working or participating in daily labor to earn income. These are opportunity costs. And then also hygiene items, not affordable, or safe water or water treatment, not affordable. So these are all economic barriers. And you see they're all on the left side. So they're all on the demand side at usually the household or at the individual level. Yeah. Of course, so cash and voucher is one adequate response to address economic demand side barriers to adequate nutrition. Yeah, so everything that is in yellow can potentially be addressed. However, it relies on a functioning supply side. So for example, if nutritious food is not available in the market, yeah, then you cannot buy it, obviously. If health services are not available or are too far or are not of sufficient quality, then having money to access these services and maybe covering some of the direct cost related to these services is not going to help. Yeah, so it really relies on the functioning supply side, and that also already indicates that cash alone often is not a promising response to address nutrition. Yeah, it can address some of the barriers, but you have to look at all the barriers together, and you probably need to have an integrated response with different components to address the most important barriers comprehensively. So cash and voucher alone is not going to do the job. If you look at the demand side also, I think a lot of the barriers are related to economic factors, but a lot of them are also related to behavioral factors. So people don't have the knowledge on nutritious diets. They don't maybe have the knowledge and skills for adequate feeding. They don't necessarily they don't consider maybe malnutrition to be a disease, so they don't seek help and treatment, etc. So I think that is also why cash, together with the social and behavioral change that tries to address some of these demand side barriers, is something that works quite well. But we'll come to that. Good. Now, based on the review of all the peer reviewed studies that are available on cash and vouchers and nutrition, as well as operational examples, the guidance identified the 5 common approaches to integrate cash and vouchers in nutrition response. Yeah, and we're going to go through these 5 and quickly look at some of the key messages. Yeah, so the first one is pairing household cash and voucher assistance with context-specific social and behavioral change communication. Yeah. So this is something that has proven to work quite well in many contexts. I think there's strong evidence for the effectiveness of this approach because essentially cash, especially cash, but also value vouchers, they give households quite a lot of choice, yeah, and that can be a good thing. But if you're trying to achieve nutrition outcomes, the money should be spent in a specific way. It should be spent on, on nutritious foods. It should be spent maybe on health seeking. It should be spent maybe on improving water and sanitation and some other things. Any other expenditure might not necessarily contribute to nutrition outcomes. So by introducing social and behavioral change messages and activities and building knowledge and skills on nutrition, on water, sanitation and health, the spending can be channeled in the right direction. So it has a positive impact on spending decisions, and positive or can have a better impact on nutrition than just giving cash without SBC. At the same time, SBC often teaches people to do certain things, but then if you don't back it up with money, they will have difficulties to implement these messages. Like, for example, you explain to somebody how a nutritious diet looks like, that it should be diversified, it should include fresh foods, it should include animal source products, etc. But all these things, they cost money. So if people then don't have enough budget available, they will not be able to go to the market and buy these things. So the cash actually can reinforce some of the SPC messages and allow people to put them into practice. So these are the two important components there. So this is something that works, has proven to work well in many contexts. Now here, pairing household assistance with individual feeding assistance. So this is classical within kind, I think classical GFD plus supplementary feeding, for example. So you try to cover household needs, but then you know that there is specific nutritious specific needs within the households of maybe pregnant and lactating women or children under the age of 2 or whatever it is. So you give a supplement that is targeted towards the individual. Yeah? And cash and vouchers can in principle be used for both, you know, especially for the household component. We know in many contexts, including Somalia, we have replaced most of the household assistance, in-kind household assistance, with cash over the last couple of years. Yeah. Now for the individual, yeah. Question? No. For the individual component, also there is experiences of using cash and vouchers, for example, fresh food vouchers to complement the household ration that gives individuals within the household specific access to nutritious foods, etc. It's also possible to give a cash top-up on top of a basic household assistance that allows people to diversify diets and do other things. Yeah. So cash and vouchers can be considered for both components. Different combinations are obviously possible, but we have to be a little bit careful with specialized nutritious foods because they are really designed and they're designed to target specific nutrient needs. They are extremely nutrient dense. So they might be difficult to replicate with locally available fresh foods or even fortified foods. That's why some of the specialized nutritious foods, we don't recommend to consider CVA as an alternative for them. Yeah. And that is mainly related to treatment. Yeah. So all the products, all the specialized nutritious food products for treatment, we don't recommend that CVA should be used as an alternative to them. However, of course, you can give CVA as household assistance and then top them up with specialized nutritious foods, for example. Yeah. The same goes, for example, for micronutrient powders, which are a very specific product. And also there, it's very difficult to replicate the same effect in terms of nutrients with what is available in the local market. So yes, I think in general, what we can say based on limited evidence of pairing these different components, cash and vouchers is certainly a very good option for the household assistance. For the individual feeding assistance, it can work in prevention for specific objectives, for example, through fresh food vouchers. But there is some evidence pointing in a direction that specialized nutritious foods for individual feeding is actually the more effective response. Yeah, but there's not that much research has really been going in that direction. Yeah. Good. That was number 2. Number 3. Cover that. Number 3, providing conditional cash transfers to incentivize attendance to priority health services. Yeah. Priority health services are those preventative health services that are known to have a very good impact on nutrition. Yeah. So antenatal care, postnatal care, vaccinations, etc. There's a list. So cash transfers can be provided conditional, as we discussed. So people only get the assistance if they show up for a specific health service, or in a lighter version, they, for example, they have to show up for an initial screening and they get maybe a health card or something like that. and then later on are encouraged to seek regular health service related to maternal or child health, but not necessarily making the assistance conditional. So then the conditionality is more for the first visit and not necessarily for all the follow-up visits. So of course there is flexibility in the design there. And this has proven to be can be an effective approach, especially in more protracted situations where organizations have actually the time and resources to set up a conditionality, and this can improve attendance to health services. Obviously, also unconditional cash transfers can achieve that. So if you give somebody money and you walk away, there is a chance that some of that money will be spent on health. So it can also increase health service attendance, but with a conditional approach, you're more likely to reach that objective. Number 4, provide CVA to facilitate access to treatment services. So here we're specifically talking about CVA that covers indirect costs. So for example, transportation or accommodation for inpatient care, or direct cost. Now, treatment services of malnutrition are or should be free, but there might still be some tests for some expenses related to additional tests or medication, etc. So that's why it's there. So these are cash transfers specifically provided to, for example, at the point of referral to access a treatment service. Can potentially also be done for preventative services. But you see the difference to the first one, where you're providing it conditional, and there the cash transfer is actually usually more household transfer to improve household food security, etc. And here it's specific amounts that help a household to cover expenses in order to access treatment services. This is something that is commonly done by nutrition actors, especially if they identify that as a key barrier, but usually very poorly documented. And then the last one is related to the treatment of SAM. And there, one approach that has been used in different contexts and also been studied is to provide caregivers who bring their children for SAM treatment with household cash or voucher assistance. Often it's actually done through cash transfers, with the objective of improving treatment outcomes. So one study in the DRC has found quite positive impacts of that approach on treatment outcomes, especially on reducing defaulting during treatment, reducing relapse into malnutrition, and improving in general household dietary diversity, but also dietary diversity of mothers and children, etc. This, however, as any assistance targeted towards malnourished children, can have or can lead to a perverse incentive. That some caregivers. Sorry, can the person mute himself? Thank you. Mute. Thank you. Can lead to perverse incentives in the sense that caregivers intentionally make or keep their children malnourished in order to receive the assistance. There is some anecdotal evidence, it's very poorly documented, but it is a risk that needs to be taken seriously. Sorry, can that person who is unmuted, can you please mute yourself? UGAS, thank you. Okay, so that's an approach that has potential, but also has important risks that need to be very closely watched. And we'll come to that because there have been 2 examples in Somalia on specifically that approach. Good. Is there any questions in relation to what I just presented very briefly? don't see anything. I hope it was fairly clear, otherwise you can bring it up later. I don't see any questions in the text box. Okay, so let's move on. Coming to Somalia. Not very clear, okay. Yes, I mean, it is quite a complex topic, the integration of cash and vouchers in nutrition programs. So I would also encourage you to attend some of the launch webinars of the guidance, where we will spend a little bit more time in explaining the different opportunities. Yeah. Coming to Somalia, here is a list of projects that were shared with me, so that I had a look at and reviewed in terms of how they worked and what kind of results they contributed to, as well as a couple of researches that were undertaken over the last couple of years. Yeah, so we have projects from the BRICS, the BRCS-IS consortium, from FAO, from ICRC, from UNICEF, and from WFP. And we have researches from University College of London, together with Concern. There were two pieces, one from 2018 and one from very recently, not yet published, and there's one from Johns Hopkins together with World Vision International that was conducted or was published earlier this year. Yeah. And looking at these different projects, essentially we can cluster them into three different approaches. Yeah, one is cash and voucher assistance paired with social and behavioral change. Yeah, one is the combination of household assistance with individual feeding assistance. Yeah, and one is the provision of household cash and voucher assistance to caregivers of SAM children who bring their children for treatment. So these are all these different projects belong to one of these categories. Yeah, and we'll quickly go through them one by one. So the first one, pairing cash and voucher assistance with social and behavioral change, with a social and behavioral change component. Yeah, and here we have what FAO did, especially their newest projects, which started in 2019 and follows the FAO's Cash Plus approach. Yeah? And essentially what it constitutes is monthly household cash transfers over 3 to 6 months, depending on, I think, the geographic location and the vulnerability of the household. A nutrition SBC component, aiming to improve food choices and utilization, and also including nutrition and food safety messages and cooking demonstrations. And these SBC activities are implemented through community nutrition champions. Yeah, it's a range of different means that are used to deliver these SBC activities. And importantly, also a livelihood support package on top of the household cash transfers and the nutrition SBC. And that constitutes of inputs, assets, as well as technical training on specific skills. Yeah, so that's a whole package, but I put it under the household cash plus SBC component. Yeah, actually, most reviewed projects had some form of SBC component. I think that's important to mention. Yeah. The most recent research by the University College of London. I'm not going to go into detail here, but it looked at, or it had quite an important SBC component, which they called mHealth, so mobile health component. Yeah, and some of the and it was implemented in around Mogadishu in camp settings, and some of the targeted beneficiaries, all of them received cash, some of them with with mHealth component, and some of them without. Yeah. And the mHealth component was delivered through mobile phone, weekly voice messages over a certain period of time, introducing different characters, so basically using storytelling and covering a whole range of topics related to nutrition, to IYCF, to health, seeking, etc. Yeah. And what the research found actually is that the mHealth component led to an increase in household expenditure on food, and on an improvement in child diversity score. So the households that received the M Health component together with the cash, they scored better, or they had better results on household expenditure and child diversity compared to the households that only received the cash. So I think that's an important finding, and I think the potential or the interesting aspect of that approach is that it's delivered through mobile phone, and as you all know, almost everybody in Somalia, almost every household in Somalia has a mobile phone. So this is potentially an approach that could be rolled out as well to other household cash transfers. Yeah. Good. So this is for pairing cash with social and behavioral change communication. Now, combining household assistance and individual feeding assistance. So we have an example from WFP, which has been using fresh food vouchers in vegetables, they call it, since 2016. And that is being provided on top of the general food distribution. So an in-kind household assistance in the form of GFD, plus an individual feeding assistance in the form of a fresh food voucher targeted specifically to pregnant and lactating women and aiming to diversify diets. Yeah. And this is provided during pregnancy. So once women's pregnancy has been identified, until 6 months after the delivery. So approximately maybe 1 year of assistance on average. The assistance is also conditional on the attendance to preventative health services and SPC activities. Yeah. And WFP in its monitoring constituted a positive impact on minimum acceptable diet for children, as well as the minimum dietary diversity for women. So again, confirming or showing that it has a positive impact on the immediate determinant of a good diet. Yeah. The ICRC also combines these two aspects in 2017-18 in a two-phased intervention, which started with the unconditional cash, which was complemented by BP5 in the first round, and then later on switched to a commodity food voucher as the household component, and supplemented by super cereal in the second and third round. And they also observed positive impacts on GAM and SAM rates among assisted households. Yeah. Good. Then lastly, what the third approach that has been observed in Somalia is the provision of cash transfers, mainly to caregivers who bring their child for the treatment of SAM. Yeah. And the first example again is from ICRC, who followed that approach from 2015 to 2018 in two treatment centers in Baidoa and Kismayo. So it was unconditional cash transfers to caregivers whose children were treated for SAM in stabilization centers. So it was for inpatient children. And the cash transfer was initiated or launched when the child was formally discharged from the treatment center. Yeah. And it was 3 rounds of $100. Yeah. So that's quite a lot of money, $300 in total, quite a significant amount. The objective was to cover transportation, to stabilize household food security following discharge, and to prevent relapse. Yeah. And the project was then stopped in 2018. I think there were rumors that unconfirmed rumors that this contributed to some households deliberately making their children malnourished, but it was never confirmed. The ICRC tried to launch a study on it, but that was then cancelled because of security restrictions. Yeah, so the ICRC was never really able to look at it. But but the cash component was stopped in 2018. UNICEF followed a kind of a similar approach, which started in 2019 and went into 2020. So the plan was to provide caregivers of SAM children with monthly cash transfers of $20 over 9 months following their enrollment at the treatment center. And the objective again was to cover basic needs as well as to prevent relapse. The project, however, was cut short because of operational and funding constraints. There was only 3 rounds of disbursement done for some of the beneficiaries, and because of other constraints as well, it was difficult to really look at the results of the intervention. Yeah. But these are 2 examples of this approach. I think the amount, of course, you see the first project provides 100 over 3 months and the second one 20 over 9 months. So quite different approaches in terms of amount. I think what we have to keep in mind here, that the higher the amount, the more incentive people have to be part of the program. Yeah. So the incentive value of cash, of course, increases with the value that is provided. Something important to keep in mind. Yeah. Quickly gonna look at the chat. Yeah, so I think there was a comment of WFP. So the e-vouchers provided on top of GFT. I think that was my point. So it's not it's GFT is provided at the household level, and then the e-voucher is provided in addition to that. Okay. There's one question in regards to how the $20 was determined. I think that would be a question for UNICEF. Maybe we can take that in the Q&A session. Yeah. So that brings us actually to the Q&A session, and I have here listed a couple of projects, but feel free to raise anything that you want in relation to your experiences, in relation to questions you had for the project that were presented. So, for example, what were some of the main challenges, additional lessons learned for those organizations that have implemented these projects? Where do you see opportunities to use CVA for nutrition outcomes in Somalia? And you see that there is more that could be done as part of the Somalia response on nutrition? And also, what kind of support from the nutrition cluster would be useful to increase the consideration and the uptake of CVA for nutrition outcomes? So these are some of the questions that are listed here, but feel free to raise anything. I would suggest that you raise your hand if you want to say something, and then I can give you the green light, yeah, so that we have a orderly discussion. So please, if you have any points, please raise your hand and you will be given the floor. Yes, Fabienne, Ahmed?
Yes, hello. Thank you so much for the very useful presentation. It gives a lot of insights, and I'm so sorry, but we couldn't be part of the reviewed projects because we are fairly new in the cash voucher assistance paired with the SBC, as well as individual feeding programs. CARE is actually funded by FFP and is doing cash transfers and conditional cash transfers in Sol and Sanag. And we are also pairing that with, behavior change communication on healthy diets, on, food education and health education to improve the care feeding practices of children of the households receiving the CVA. So what we are now also trying to do as a learning experience is we're trying to collect nutritional screening of data and compare it with the households that have not received CVA. So I was wondering, in the project that I think ICRC did, which is quite similar to what we're kind of aiming at in trying to look at the nutritional outcomes and specifically the SAM and MAM changes. I was wondering whether they did this in a control group or whether they basically only screened the children who were in the CVA cash group, or whether they had a control group to compare the SAM and MAM rates with.
Okay, thank you for that question. Is anybody from ICRC on the line? Actually, I don't know, but I think I know the answer to the question. Was anybody from ICRC on the line? No, probably not. Okay, so I don't think they used a control group. I would be very surprised. So I don't think they did. So they probably looked at baseline and end line and at changes there, and they might have compared it also with some of the reference data for regions. I'm not sure, but I can give you the contact for the ICRC nutritionist that is working on Somalia. If you would be interested, I can send you the email. If you want me to send you the email, just write me one. My email is included in the first page of the slides, so I'm just going to put it here. So just send me an email and I'll put you in touch with the ICRC nutritionist.
Excellent, thank you so much. And yes, just as a point for the nutrition cluster, we will be doing the learning exercise where we actually document the households versus control group. So we'll be sharing that with the cluster as a whole, and hopefully we can learn also from that and see whether there is actually a difference between the households with the cash and nutrition or cash plus versus only nutrition without cash.
That's great.
So we'll share that in the next coming few weeks with the cluster. Maybe that can also be.
Yeah.
Thank you.
Thank you very much. So yeah, I think it's very important. I mean, the evidence base in general for using cash margins for nutrition is increasing, but it's not rock solid, especially for some of the approaches. So the guidance and evidence note that I'm producing is based on what we know. I think there's definitely a need for nutrition practitioners to start to use some of these approaches because there is encouraging evidence. But at the same time, it's extremely important that whatever you guys do, whatever new approaches you try to document them, try to monitor them to the extent possible, and then also share with the wider community of practice so that we can learn together and improve the evidence base, and then also improve the approaches and the guidance over the years. So I think that's a very important point. Then I saw one question: $100 for SAM child admitted in SC. Is it meant for malnourished child to access diet or household? So the $100 that was provided from the ICRC was really a household contribution over 3 months. To unconditional, unrestricted, so they could do whatever they wanted with it. But I think it was really meant to improve the household food security following the discharge of the child, so that the child would be returned into a better environment. Maybe that some investments into livelihoods could happen, and that the risk of relapse would be reduced. So that was really the idea. And you can see that the amounts are, from $20 to $100. I think also the amounts for cash being provided in Somalia, they vary quite significantly. I think in the end, it depends on the objectives that you have and what you want households to be able to buy and access over a certain period of time. Yeah. So of course, there's different rationales for amounts, but definitely also need to be more harmonized. Yeah. I can see one more comment here, but if you have additional questions, please raise your hand. No? So I'm going to read it from Mohammed. Appreciate if you can share any negative impact on cash assistance linked with interventions, like increase of admissions for the basis to get the cash assistance, incentivizing malnutrition. Yeah, so as I mentioned, that's for the approach number. For any approach where you target your cash assistance or in fact any kind of assistance based on the nutritional status of a child, you might incentivize behaviors that are not productive, or that are negative from a nutrition perspective. We know, for example, I know that in Nigeria, ACF had a project that did exactly that, and they saw quite a large increase in admissions following the initiation of the cash transfers to caregivers. So more people brought their children for treatment. That is not necessarily a bad thing if all these children actually were malnourished in the first place. But it would, of course, be a very bad thing if some of them were not malnourished and then were made malnourished and then brought to the stabilization centers. So, like I said, there is some anecdotal evidence that this has happened in certain contexts, but it's very well documented. It's very unclear whether it's maybe related to contextual and to cultural factors. And it's very unclear what the degree of the problem is, whether it happens maybe 1 out of 1,000 households, or whether it is a problem that is more widespread. So we have still a lot to learn when it comes to understanding some of these risks. But at the same time, as I said, the providing household transfers to caregivers who bring their children for SAM treatment has a lot of benefits in terms of improved treatment outcomes. So I think that has to be kept in mind. And if an organization goes down that road and chooses that approach, I think it's extremely important to very closely work with the communities to identify that risk, to see whether it is actually a risk, and then once the project launches, to monitor the risk very closely, so that the organizations can react if they see that this risk is actually is something that happens among certain households. I have one comment from SOADO program. Please go ahead. You're muted. SOADO. I have a raised hand there. I will write. Okay, please write. Okay, all right. So that person will write. Maybe also if you, I'm just going to put that question to you, and if you have any idea, also write it into the text box. So specifically the question, what kind of support from the nutrition cluster would be useful to increase the uptake of CVA nutrition? So what kind of support would you require in terms of training, technical support, potentially advocacy, etc. So maybe if you have some ideas, please write them also in the text box. I'll give you maybe 1 minute, and we're waiting for the person to write the comment. And if we don't receive anything, I think we'll also move on to the next topic. So what kind of support from the nutrition cluster in Somalia would be useful for you, for your organization, to increase the consideration and the uptake of CVA in nutrition?
Andre, I think there was also a question from Emma.
Yeah. Did I see? I didn't see that. Where is that?
Sorry. So Emma asked, do you have examples of cash modalities that have encouraged communities to be resilient to different kinds of shocks?
In the context of a nutrition response? Or more broadly?
You can elaborate on the question.
My question is, can you hear me?
Yeah.
Yeah. Because most of the modalities that we see are just giving cash and nothing else after
Yeah,
that.
yeah,
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 so be
yeah.
a change in cash. Are there any modalities that contribute broadly towards preventing malnutrition as opposed to just treatment?
Yeah,
Over.
exactly. I think that's a very valid question because yes, cash transfers, if they're really just focusing on basic needs, they are a temporary increase in income, but they might not necessarily lead to a more sustainable income flow. Was this Emma from FAO?
Yeah, yep.
Yeah, so I think your project is actually an example. I mean, whatever you can do actually to increase the livelihood component of households, I think that is going in the right direction. So your asset program together with technical skills definitely is going in that direction. The different organizations are using different kind of graduation approaches, which usually consist of a household assistance to stabilize the household over a certain period of time, social and behavioral change, technical training, and asset transfer. That's usually the package of a graduation approach that can be used. I think there's positive examples where good results have been documented, and then there's other examples where it might not be working. It depends a lot on the vulnerability of the household. Like if you have a household that is female headed and the woman has 3 children, then it might be a bit more challenging to make her earn her own income if she doesn't necessarily have the capacity or the time to do so, or if you have households with people with disabilities, etc. Then it might be more difficult to really strengthen their resilience in kind of strengthening their ability to generate income or to grow food. Yeah, and therefore for the most vulnerable households that might not have the potential to be more resilient from a nutrition perspective. And of course, ideally, there might be a possibility to hand over these caseloads as well to maybe more long-term government-led safety nets, if they exist. But I know in Somalia it might be a little bit more difficult, although I know that there's a lot of efforts from humanitarian actors to strengthen safety nets, and also efforts from the government to do the same. So there might be opportunities there. But yeah, I think your example, the FAO's Cash Plus approach is actually a good example in an attempt to strengthen the resilience of households vis-a-vis sustainable nutrition outcomes and shocks. And then we have a couple of more points. Let me just quickly go through them. So here we have from Tayyip Ismail, malnutrition causal factors relates poor behavioral practice not related to lack of household income. Could be more beautiful if you can share any scientific research that underlines how cash programming can be fit to all or some causal factors. Not sure I understand the question. Like I said, cash and voucher modalities are primarily suited to address the economic demand side barriers. So they need to be complemented with other interventions that address some of the other barriers on the demand side, like for example, social and behavioral change, or on the supply side, like supply side interventions, market-based interventions, strengthening food production, strengthening the availability of nutritious foods in the market, strengthening the capacity of the health sector, etc. So these are some of the complementary measures that are required to have a comprehensive response. Then we have similar trainings and discussions. Thank you. Okay, I think that's related to what the nutrition cluster can do. And Suado, we're implementing an agricultural project which supports sweet potato planting. The crop is very rich in vitamin A, so it could be an opportunity for nutrition raising income. Yeah, definitely. Like I said, I think it's extremely important to work on both sides. So the demand side of nutrition barriers, as well as the supply side. And on the supply side, availability of nutritious foods, the production of foods in general, the availability of foods in general. I think these are some very important components that need to be strengthened at the same time. Now, with a voucher component, maybe potentially you can even link these two, so to give people access to locally grown nutritious foods, for example, or you can support local farmers with cash grants or vouchers to access agricultural inputs to help them to increase their production, etc. So there's different things you can do. I didn't go into the whole opportunities to use cash and vouchers for livelihoods, because it's a kind of an additional debate. But there is certainly opportunities there. And like I said, extremely important from a nutrition perspective to work on both sides, on the demand side and on the supply side, to have good results. Then we have something from Elite Relief Society. Mission of the referral before that we won't know where to. I'm not sure I understand that one. Okay, maybe that person can elaborate. Raise your hand. I'm not sure I understand that point. Is there plans to harmonize entitlements for both conditional and non-conditional cash transfer projects? So very briefly, but if somebody from the cash working group is on board, I think they can supplement. But I think for multi-purpose grants, there is already quite a strong effort to have the amounts based on a minimum expenditure basket, and then to have the transfer amount based on that minimum expenditure basket. Now, the minimum expenditure basket is of course going to cost you a different amount in different regions because the prices are differently. So I think the important thing is actually not necessarily to harmonize the amount, but to harmonize the basis of calculation, so that people with the money that they get can buy the same amount of things. Yeah. For other programs, yes, who is it?
Thank you for no.
Yes, please go ahead. Go ahead, then. Yeah, please.
Yeah, thank you for clarifying about the transfer values. I was going to provide a closing remarks, because I've seen there was a couple of comments in the chat box saying that $100 is high and $20 is low. We have Mary Karanja, the Cash Working Group coordinator, who's also on the line, and she will provide us with an update either now or at the end of the webinar, where we are with the formal revision of the MEB. I also would like to clarify that $100 is the average cost of the MEB in Somalia. However, there are some regional discrepancy, as you mentioned, just because in some rural location, markets are not that integrated, so the cost of basic food is higher. But the Cash Working Group is definitely aware of the situation, and they're working towards revising the transfer values. Mary, would you like to share some feedback on the revision now, or would you like to wait towards the end of the webinar?
I could do it now. Over.
Okay, go ahead.
Okay, so just a background. So to determine the transfer value recommendations, the Cash Working Group uses the MEB. So the full MEB, which has the non-food items, but also the food MEB. So what has happened over time, as you know, we have different regions in Somalia. So this is determined by the markets of the different regions. We cannot have one that cuts across all because of the differing contexts in Somalia. So what is happening is that the Cash Working Group, together with the Somalia Cash Consortium, there is a plan to review the minimum expenditure basket, basically to redesign the minimum expenditure basket, looking at the components of the minimum expenditure baskets. So basically, what commodities would a household in Somalia need in order to meet the humanitarian basic needs? So for non-food items and for the food basket. So we have a plan There's a plan to do this. This was supposed to happen using HEA approach. It was supposed to happen in the first quarter of 2020, but then COVID happened. So there've been restrictions, and it was put on hold until we are able to sort out the data collection, and hopefully now we'll be able to start the data collections in the fall of 2020. So what will happen? So during the process of this is that the consultant will be talking to the different clusters to look at the sector-specific MEBs. So talking also to the nutrition cluster to look at the nutrition specific MEB for the food basket, and then these will feed into the determination of the full MEB, but also in terms of the transfer value packages that could also look at different packages, also looking at different sectors. Over.
Thank you very much.
This clarifies a lot.
Thank you.
Okay, I think considering the time, I think it's best probably to move on. I saw some additional questions here. If you have any technical questions in regards to CVA and nutrition, please get in touch with Noan or me, and we will be able to point you in the right direction. Now, very, very briefly, we're going to talk a bit more specifically about cash transfers in Somalia. Because as you can see here from this chart, there's out of the total requirement of the HRP for 2020, and of course we know now with COVID that everything has changed quite significantly, but the plan was for cash and voucher modalities to have a budget of 1 billion, so 32% of planned activities were going to be implemented with cash and vouchers. And you see here the percentage of the cash and voucher component for the different sectors. So multi-purpose cash obviously is 100% cash, 29 million. But then you see in food security, for example, 55% of all interventions through cash and vouchers, and that represents 209 million. So that's a lot of money. And nutrition, as already mentioned by Noan, a very small amount at the moment. But of course, before we were talking about integrating cash and voucher modalities in a nutrition response. Now we're talking about cash transfers that are not necessarily or not at all actually targeted towards nutrition outcomes. But still, if we use cash transfers, for example, in food security or maybe in WASH or sometimes in other sectors, there's certain things that we can do to increase our chances that these cash transfers contribute to nutrition outcomes. We're talking about applying a nutrition lens to cash transfers provided at the household level. I think there's a lot of potential there, especially in Somalia, to take measures to improve or to apply a much stronger nutrition lens to the cash transfers that are already happening. And there is essentially 3 main measures that can be taken. One of them already discussed is to add a social and behavioral change component targeted towards nutrition and health. And we saw that, for example, the e-health component of the research by the University College of London could be an interesting model maybe for some other interventions or other things that actors are doing on the ground. The second thing is really targeting. So paying specific attention to at-risk groups to malnutrition in the targeting of cash transfers, for example, for food security, or of targeting of multi-purpose cash grants. So these are typically pregnant and lactating women, children under the age of 2, children under the age of 5, and some others. And here, of course, we also have the 1,000 days window of opportunity that all nutritionists are aware of. So the time from the pregnancy until the child's 2nd birthday, and that is a very crucial time in terms of cognitive development, where adequate nutrition is extremely crucial for the future potential of the child. And that can also be used as an entry point to target household cash transfers. And lastly, one thing I want to mention, we should be a bit cautious in targeting cash transfers based on nutrition status. Now, if it's integrated within a treatment response, that can be a good thing, and we saw that can be a valid approach to improve treatment outcomes. But if nutrition status is only used as a targeting criteria and is kind of treated apart from the treatment intervention, then I would recommend against it. Yeah. And then lastly, the third key measure to be taken is to make sure that the minimum expenditure basket, or any expenditure basket used, so it can be a minimum food basket, and the transfer amount are sufficient to reflect a healthy and nutritious diet, and potentially some other expenditures that are important to a nutrition outcome. So, and for that, I'm going to hand over to Noan.
Yes, thank you. What a great segue. So as mentioned before, the minimum expenditure basket, the MEB, is a summary of needs and services that is required by a household in order to live with dignity. You might have heard SMEB as well. So SMEB, the difference is like a survival minimum expenditure basket. So only very essential needs for survival is considered in the basket. So what is important to remember is that the calculation of MEB is not an exact science. Even if evidence is used to determine what constitutes an MEB, decision on what to include or leave out always involve compromise and subjective judgment. So the MEB is simply a threshold calculation, and it can serve as a foundation for quality response. What is also very important to bear in mind is that the MEB should not be critiqued, but we can look at the MEB as an opportunity to build on top of it or around it. So any gaps that is not represented in MEB is an opportunity to be addressed with cash and vouchers assistance. So currently the Somalia MEB only constitutes of 4 food items. So it's an energy-based MEB. We have cereal, oil, cowpeas, and sugar in an MEB. And from a nutrition perspective, it falls a little bit short on the provision of a nutritious diet. So as you see, the MEB in Somalia is about $100 per household, but there's regional variations because sometimes the food commodities are expensive in some other locations. So yeah, so there's a variations of cost that is calculated around it. However, the transfer cost of multipurpose cash assistance is 80% of the overall MEB of whatever the amount. It would be 80% of the overall MEB. And so the cost of diet exercise. So basically, WFP launched a study in 2019, which was the Fill the Nutrition Gap study. So the study was to show the difference between a nutritious diet and an energy-based diet. So basically, the study taught us that a nutritious diet is on average 4 times the cost of an energy-based diet. Also, I think I will now pass over to Save the Children, Aiden, who will show the cost of a nutritious diet and will explain the approach of calculating a nutritious diet, and we can come back to discuss of the different elements in the diet. Over to you, Aiden, if you can share your screen and project the Excel sheet.
Thank you, Marie, but I request access to share, as the screen could not give me an access to share. So I will request from host to give me access.
Then you can share. You can share. Even and Noan and Andrew are using it. They're sharing the representation. So just go to share screen, then it will automatically take. Yes, I think it only needs. Yeah. Yes.
You
Good.
see now.
Exactly.
Okay. Thank you very much for all of you. This is Aden Mahdi from Save the Children. Before going through this, let me give you a background information that we have done during our discussion on the last couple of 2 weeks. We were a lot of people who were working with this, particularly Concern Worldwide and Hassan Sharif as well, and the rest of the team were also supporting us. So as you can understand here, the Nutritious MAP or minimum expenditure basket that we have here, it is only secondary data that we have received or gotten from the WFP surveys, and also our discussions among the teams and stakeholders. Because of due to COVID-19, we could not go out and conduct primary data. So that this is the secondary data, and our discussion is that for that reason, we have our reference on that. The other thing that we have here is the decision to each of each commodity in the basket was also based on the availability in the market, access, value for money, and preference for the population group. That is also we have considered. The challenge that we have, it's time constraints and difficult to conduct, as I've already mentioned, the interview with IDP community. So this food basket mostly we have produced is for poor people or vulnerable people living in Mogadishu. Only this is for Mogadishu. We could not go Baidoa and Hargeisa because it was time pressure, and also we have other duties from our organizations. The food basket, just like any other minimum expenditure basket, does not mean to account for additional requirement for all other groups, such as pregnant and lactating women, infant and young children, adolescents, elder people, disabled people. So this is a holistic food that everyone can benefit, can use it without any other. That's our introduction and overview of the process. So this the methodology. If we go back, come into this Excel sheet, the methodology that we have used is we have collected this information, and we have choice. Our choice was these items here. And after column P, we have this spreadsheet. We entered the NUTVAL to calculate the macro and micronutrients to design food basket representing 1,800 kilocalories per person per day. That is what does this column P tells us. We have rice, beans, wheat, or grain, legumes, cereals, fat, vegetable, condiments, vegetables, protein, and dairy. So this is the type of food that we have agreed to present by today. The next was we have measured each person's requirement for monthly basis on monthly basis. By this price, we have also taken from WFP market monitoring data, and also the prices now we have taken from the market because of due to COVID-19, the price has already also going up. For that reason, sometimes we were referencing to market value, market price at the moment. Therefore, in column C, it is the calculation by person per food item per month. Then the column D is the price per that food item, and column E is a neutral calculation per person per month times number of people average household. And the next column of the might be a cost per household. First of all, we have received the cost per person. Then we have multiplied by number of people in that household. We mostly use the average household of Somali population, which is 6 persons per household, as we do all the surveys and other assessments. That has given us the cost per household per each item of the food commodity, as you can understand. Some foods are so expensive, might be the meat. We have referenced goat meat, which is $4 minimum, which is very high expensive when we compare it to the purchasing power of the community of the poor and vulnerable populations. For that reason, our intention was just to discuss, and again, we can also change, as this is very high expensive, to less expensive or very cheap commodity that also can be received from the protein that we could get from meat, such as fish, also eggs, also chicken. If sometimes chicken is cheaper than meat, as we practice in the markets of Mogadishu, as well as the eggs, as well as the fish. So the importance is we need is to keep the source of protein in the diet as long as the commodity is appropriate for the target population of any kind. Then we have column I. This column I, it is meaning that it's a checklist to confirm that the food choice is appropriate for the target population. So we have understood that we said yes or no when we were discussing for holistic food minimum expenditure bucket approach. It's recommended also it is needed to discuss with the target populations as focus group discussion or interview or key informant interviews to assess their food preferences, consumption behavior, and cultural difference. An item is purchased.
Sorry, just because we're running out of time. Can you just scroll down and show the total cost for
the total cost per family per month? We agreed that it is 252.3 per month.
And that compares to at the moment?
Yeah.
This compares to how much at the moment for the food component on average? It's approximately 100, right?
Yeah.
Or
yes,
even less?
Yes, it is 100. The average is 100, yes.
Yeah, okay, great. So I think the main message here, sorry to interrupt, because I think it would be good to move on. Some people might have to be leaving. But I think the main message really to show that the diet that you, or the diet that you have put together here, which represents a nutritious diet and is able to cover more or less the micronutrient requirements as well, is significantly more expensive than the current one, which is more energy based.
Yeah, due to this this time is it is COVID-19, all the prices went up. So maybe sometimes back or after COVID-19 ends, maybe some prices can change. But this time it is due to COVID-19. This is the price that we have received from the markets as well as from the WFP data.
Exactly. So the COVID-19 crisis is making the problem of affordability of a healthy diet even worse. So for people at the moment to be able to purchase and access a healthy diet is even more difficult. Okay.
But also, it's not very far away from what was produced in 2019 by WFP, because they calculated on the basis of, I think, 5 households, and it was 209 per month. And now this was calculated on the basis of 6 people per household, and we have 252 per month, given that, you know, there were expensive commodities like meat that were considered in the basket, but this can be substituted with other cheaper variation of protein. So this is just an example as well on what constitutes of a nutritious and healthy diet. But there's ways to play around with the commodity as COVID-19 you know, subsides, and we'll have a broader choices of basic food on the markets.
Good. Okay. Yeah, so that's one question. Yeah. So a nutritious diet is basically a diet that is able to fulfill the macro and micronutrient requirements of the general population. An energy-based diet is a diet that is primarily focused on macronutrient requirements and falls often short of micronutrient requirements, so minerals and vitamins. Yeah, so that's the main difference. And of course, if you want to have a nutritious and healthy diet and not only cover the calorie requirements, it requires a different diversity, and it requires different foods, especially fresh foods and animal source foods that are quite considerably more expensive per calorie than the regular staple foods.
Yes.
So that is really the main difference. And based on experiences from the cost of the diet, exercises around the world, usually a nutritious diet costs between 3 to 4 times the price of a solely energy-based diet. Yeah, just as a bit of background.
And also, usually nutritious diet doesn't consider some elements that is pictured here, like vegetables such as tomato and fruit.
Yeah, exactly.
Banana. So this is just a wish list. It's just to show how the exercise was conducted and what is usually part of a nutritious diet. But as I mentioned, there's opportunities to bring the cost down. Yeah, as we progress along with the formal revision of the MEB in Somalia.
Yeah. Okay. Is it Ahmed Mahdi, or what does he stand for? Sorry. Can you stop sharing your screen, please?
This is Adam. Can I stop sharing?
Yes. Thank you very much,
Yes.
Aiden.
Thank you very much.
Great. Okay, so there's a follow-up question. Okay, so in the MEB, how much is actually the food component? I think, yeah. Do you know that on the top of your head, Anon? It's probably around 50% or more, no? Anyway, I think we can easily find out. Let me just see.
Sorry, it's on the Cash Working Group webpage. If you can just pull it up. Or Mary, are you still with us? Maybe you know the answer on top of your head.
Okay, I think we can address that at a later stage. Just
yeah, no problem.
Okay, there's the recommendations left. I'm not going to now read all of them for those interested. I think the report is available, the draft report. But maybe we can give the floor back to Faisal and Noan if there's anything you want to point out, or open the floor very briefly for some final reflections, because we're already 10 minutes over time.
I would just like to add that is a really important piece of work that you're doing globally, and guidance is much needed in the use of cash in nutrition. And I'm hopeful that the nutrition cluster would push the agenda forward, especially now that we have a very active task force within the nutrition cluster. So yeah, a webinar like such would be conducted routinely to address some of the recommendation that was given also by partners in terms of areas that they would require support, and how we can continue to build the knowledge as we move along. Also, Mary has mentioned that you know, this exercise that we did with the task force in terms of designing this nutritious basket is very important and will be utilized later on when they launch the formal revision of the MEB. So special thanks to the nutrition cluster and the task force for their hard work. Over to Faisal and Naima, maybe they would like to add something as well.
Yeah, if I can go first. Thank you, Noan, and thank you, Andre, for the really informative and relevant webinar this morning. This important work is going to allow us to tackle the high levels of acute malnutrition in the country. We're not saying all nutrition partners have to implement CVAs, but we want to make sure when opportunities are present that these programs can be interlinked for better outcomes for children and women in Somalia. The conversation will certainly continue. The MEB as a nutrition sensitive will be refined some more, and we'll be able to hit a sweet spot on what works for Somalia. Thank you for all the participants. We look forward to the learnings that the different NGOs are doing and build on evidence that are specific to the country. We'll also be sharing out what Andre has been working on at the global level, and tying together what all the other agencies and partners have been doing for your inputs, for your comments, and for your review. Yeah, so all in all, thank you very much, and we shall continue this conversation. Over for me. Yeah, I think we can end it there, unless there are any burning questions. Thank you. Have a good rest of the day.
Thank you, Naima. Bye, everyone.
Bye-bye, everyone. Thank you very much.
Thank you. Bye.
Bye. Thank you. Bye.
Thank you. Bye.
Thank you, guys. Bye.
Thank you. Bye.
Thank you. Bye, everyone.
Thank you.